Hello everyone, welcome back to my YouTube channel nursing.com. So today we are going to learn about Indian childhood cirrhosis in pediatrics. तो चलिए शुरू करते हैं इंट्रोडक्शन से. Indian childhood cirrhosis is a chronic liver disease primarily affecting young children, characterized by the buildup of copper in the liver and the development of cirrhosis. ICC usually occurs between 6 months and 4 years of age. It is progressive disease with abdominal distension, marked irritability, unexplained irregular low-grade fever, hepatosplenomegaly with hepatic failure, ascites and jaundice. Epidemiology. In that, the disease is prevalent all over India in some particular communities. Male children are 4 times more suffer than female. The firstborn child is at greater risk. Large number of cases belongs to the low middle class family of rural areas with vegetarian food habits. There is familial predisposition of the disease. At present, there is remarkable decline in the incidence of ICC, which appears to be related to decline practicing of use of copper or brass utensils for boiling milk. Etiology. Hepatotoxic agents. In that, hepatotoxic harmful agents like gutties or aspergillus flavus that grow on groundnuts, maize and rice may cause ICC through the cause and effects relationship is not fully understood. Use of copper utensils for boiling milk or cooking food and early weaning with milk supplement before the age of 3 months may have some influence for occurrence of ICC. Metabolic defects. In that, these may cause ICC, especially disturbed lactose, zinc, copper and magnesium metabolism. Immunological disturbances. In that, these are found in high levels of circulating immune complexes, which can cause immune-mediated injury of the liver. Genetic factors. In that, familial occurrence of ICC points the possibility of underlying genetic factors along with environmental factors. Nutritional factors. In that, previously it was believed that malnutrition was an important cause of cirrhosis. At present, it does not seem to play clear role in its pathogenesis. Viral infections. In that, ICC has been thought to be a consequence of neonatal hepatitis or infective hepatitis, though there are some objections of this hypothesis. No single factor seems to be the cause of ICC. Multiple factors are responsible for occurrence of the disease. The role of nutrition in viral infection is considered as remote. Pathology. In that, there is variation of size of the liver and color, which ranges from grey to frank green due to the disease process. The basic pathologic change is the diffuse liver damage by way of degeneration going on necrosis and replacement fibrosis. The capsule shows patchy thickening and the surface is finely nodular. The microscopic study shows marked hepatocyte damage is degenerative change in the cytoplasm. Kupffer cell shows mild degree of proliferation. Gross pericellular fibrosis in the hepatic lobule is found. Intracellular hyaline called as Mallory's hyaline are seen. There is gross excess of copper and copper-associated protein. Clinical manifestations. In that, the onset of disease can be insidious or acute. There are 3 arbitrary stages in insidious onset which tends to merge each other: irritability, disturbed appetite, abdominal distension, choky and pasty stools with constipation or diarrhea. Mild fever, progressive growth failure usually presents in spite of adequate diet. Within few months to a year, there is hepatomegaly, jaundice, features of portal hypertension including splenomegaly, ascites, hematemesis, anemia, prominent superficial abdominal veins. Intravascular hemolysis. In the terminal stage, the child becomes apathic, emaciated with deep jaundice. Liver is usually gross, enlarged with protuberant abdomen. Acute onset ICC may present with sudden appearance of jaundice, clay-colored stool and hepatomegaly. The children generally have hepatic failure and intercurrent infections which may be fatal. Duration of illness may be 6 months to 3 years. Hepatic coma may develop rapidly, leading to fatal outcome of the disease. Some children may become symptomatic for variable period and again appearance of features may found which behave like ICC of insidious onset. Diagnostic finding. In that, history collection, physical examination, liver function test, liver biopsy, cupriuresis test may be performed by oral administration of D-penicillamine. Using urinary copper or creatinine ratio as the index parameter. Sensitivity and specificity with positive and negative value are obtained. Management of ICC. In that, few cases of ICC improve spontaneously and survive without specific treatment. D-penicillamine therapy is used as copper chelating agent from liver, which improves the survivals. Immunomodulating agents like levamisole, corticosteroids, gamma globulins may also be used. Symptomatic treatment should be done specially for infections and vitamins and minerals deficiency. Supportive care should be provided as rest, diet with good quality proteins, IV glucose drip, oxygen therapy, antibiotic therapy, and good nursing care. Hepatic coma or pre-coma should be detected early for prompt management. Nursing interventions. In that, improving nutritional status, promoting of activity tolerance, protecting skin integrity, preventing injury and bleeding, expert care for unconscious patient. In case of portal hypertension causing hematemesis. In that, Sangastecan tube may be help to control esophageal bleeding. Exchange transfusion may be effective to remove circulating toxins. Breastfeeding up to 6 months. Avoiding boiling of milk in copper or copper alloy pots. Portocaval anastomosis may be done to relieve the portal hypertension and complications of hypersplenism. Increased public awareness, lowering of copper intake through copper-rich food, water and utensils. Thanks for watching.